And, and as someone who cared for someone confronting dementia, my mother who needed palliative, this session is particularly meaningful to me. So I am, of course, grateful to the work that Dr. Esch does and the opportunity to welcome you all to today's Ask the Expert program. As you may know, the Alzheimer's Association works on both national and local levels to ensure care and support for all those affected by Alzheimer's and other dementias, largely through the association's 6 core programs: care consultations, consumer education programs, early state engagement programs, information and referral services, and of course, support groups. That might sound like 5, but I believe that's 6. As part of that, the New York City chapter offers education programs on a wide range of topics. But to address questions and topics beyond those covered in those standard offerings, the New York City chapter launched this series that we're here for this afternoon, Ask the Expert, which are free virtual education programs featuring external experts addressing subjects of particular interest to all people who are confronting dementia, and of course, as you know, the people on this call. I, however, am not that expert. But before introducing today's real expert, Dr. Andy Esch, I can share some basic information and an overview of the resources that the Alzheimer's Association can provide to make sure you know where you can turn for its support. First of all, and this won't surprise many of you on this call, but dementia is a profound disease. More than 6 million Americans have been diagnosed with Alzheimer's, and the totals with Alzheimer's or another form of dementia are even higher. Over 11 million Americans provide unpaid care for people with Alzheimer's or other dementias, as I had. These caregivers provide more than 16 billion hours, valued at over $271 billion. And of course, for caregivers, the cost for any one person is what can become truly debilitating, and why care that we're discussing this afternoon can be so helpful at a very difficult time. Nationwide and worldwide, it won't surprise you, the numbers are staggering. And as you see on this slide, just one example, in the last 2 decades, deaths from heart disease have decreased, which is, of course, absolutely to celebrate, while unfortunately, deaths from Alzheimer's disease has more than doubled in that time. As I said, staggering. And by the way, all the information on this slide is from this year's Alzheimer's Association Facts and Figures report, which provides an annual in-depth look at the latest statistics on Alzheimer's disease prevalence, mortality, caregiving, and the cost of care, which highlights, I think, why the work that the association does is so important and needed now more than ever. And that, of course, leads us to our mission. The Alzheimer's Association leads the way to end Alzheimer's and all other dementia. How does it do that? By accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. And the Alzheimer's Association believes that diverse perspectives are critical, and that all communities should have a fair and just opportunity for early diagnosis and access to risk reduction and quality care. The association is therefore committed to engaging underrepresented, underserved, and historically marginalized communities, and responding with resources and education to address the disproportionate impact of Alzheimer's and dementia. And finally, before I introduce Dr. Esch, we want to make sure that everyone on this call, and spread the word, knows about the ways the Alzheimer's Association can be helpful to you. No matter where you are on your journey, you're not alone. I know I reached out to them when I was on my journey, when I began my journey, and throughout every step. And there are some very, very helpful resources. I have the number memorized, the helpline, 800-272-3900. I often joke that I have that phone number memorized, but not my girlfriend's phone number, and I blame cell phones, but nevertheless, that number is very important. Remember it. It's available to you around the clock, 365 days a year, in a number of languages. It's a free service that will connect you with specialists and master's level clinicians for confidential support for all people living with dementia, caregivers, families, the public, anyone that helps you help them. And when in doubt, the place to start is the website, alz.org, alz.org. That's where you'll find local programs, services, and support groups. And of course, it will connect you with a community that can be helpful in real life, or as the kids say, IRL. And that's where you can also connect with the Community Resource Finder, communityresourcefinder.org. Two websites that are very, very helpful. Now, let's get started with the real expert of the hour. Dr. Andrew Esch, is a senior education advisor at the Center to Advance Palliative Care. He's been there for a decade. As a palliative care specialist, Dr. Esch focuses on improving quality of life for patients and families living with this serious illness. I wish I had met him a decade ago. And he has earned his MD from the U of B, the University of Buffalo. So with that having been said, Dr. Esch, the floor is yours.
Thank you so much, Kevin. Appreciate it. Let me just get the slides up here and we'll get underway. So first of all, thank you for having me. I always feel a little awkward, being referred to as an expert, because I've taken care of a lot of patients with dementia, and I've had experience in my own family as well as a caregiver for a grandparent and an aunt at different times. And I almost feel like the more exposure I get, I know what the needs are, and I think I've gotten better through my career at helping patients and families address those needs, families in particular, but expertise feels just out of reach for me. But we keep working at it, and I think there's a lot we can do. And so as we talk about living with dementia and how palliative care can help, the focus is going to be not so much on the new drugs that were improved in the last year and things like that, but what is it like to live with this disease, and what support can palliative care help in addition to the other disease targeted treatments and specialty level care that the patient may be getting. So we really want to describe what palliative care is and who can benefit. We want to describe how and when palliative care can help people living with dementia, and especially the caregivers and families. And really, what are the resources available in addition to the ones that were already sort of laid out to get further information about how to help your loved one in the form of, palliative care resources. I'm going to try to work through these slides fairly quickly, not rushing, but just I've presented with this group before, and I feel like the real richness in any interaction with this group comes from the Q&A. So I want to leave plenty of time for that. So be jotting down your thoughts or comments or questions as we're going along. So it may, as time goes on, I'm hoping that these slides become less and less necessary, but there's still a lot of misconception about what palliative care is. So we'll work through a definition that I think is fairly easy to understand and really captures the essence of what we do, which is basically palliative care being specialized medical care for people living with serious illness. It focuses on the relief of symptoms and the stresses of the illness, and the goal really is to improve the quality of life for the patient and for the family. It is specialty level care because it's done by a specialty trained team of doctors, nurses, and other specialists. This includes social work, chaplaincy. Depending where you are in the country, it may include other specialists as well, but it is really an interprofessional group of people who work together in addition to all the other doctors involved to provide an extra layer of support. The first misconception, I think, is that if you opt for palliative care, it means you're giving up other things targeted towards cure or targeted towards slowing down disease progression. That's just not the case, which makes palliative care appropriate at any stage and at any age in somebody's illness. It is not tied to prognosis. So you can be very early on in any serious illness, even dementia, and it can be provided along with all other care. So that's one of the points I hope that y'all remember from the time we spend here today together. So why do it? Well, I mean, with any serious illness, and dementia, maybe even more so than others, quality of life is just absolutely upended, and it is affected in every way. most patients with dementia have other medical conditions at the same time that are also being treated. Those can also complicate quality of life issues. And by integrating palliative care early with everything that's going on with the dementia diagnosis and maybe all the other medical diagnoses that may be going along with it, it can lead to better outcomes, better quality of life. And there's even, journal evidence, which I think we'll get to in a bit here, that you may even live longer if you integrate palliative care with traditional best care towards the disease as well. So the key benefits of palliative care is its focus on quality of life, the fact that you can get it at any point in your serious illness, and that you don't have to give up other treatments. It really, I spend way more time in my career listening than I do talking. And so by doing that, it helps me understand what the needs of the patients and caregivers are. And then we can take that information to try to match it to treatment goals or just goals for living, life in the time you have left. So we do this through a team of providers. There's no way that I could provide everything that somebody suffering with dementia and all the people that care about them. There's no way that I could meet the needs of all those people. We need social work. We need nursing. We need chaplaincy in some cases. We need medical expertise that I might bring to the table. But we are too complex of organisms to think that one person could possibly understand everything that an individual is going through and have the training to address that in a meaningful way. Because the ultimate goal is to really give you an extra layer of support to make it so that while you're living with your illness, you're living the best that you possibly can. So again, I'm hoping someday we take these slides right out of here, but right now, public understanding of palliative care still is pretty low. But we have done focus groups, we have done surveying, and we gave people the definition of palliative care. And once they were informed about what palliative care was, and this was defining it as an extra layer of support, can be given at any time, can be done with other medical treatments. Once we explained that to people, they were very positive about it. 90% said they would consider palliative care for themselves or others. 94% believed that they should have access to palliative care at all hospitals. And 78% agreed that it was important to patients and their families that they be educated about what palliative care is, and that it is available with other curative treatments. So when people were made aware of what palliative care is, the overall response was pretty well. It was pretty good. So, with dementia, we list the slides as special challenges, but the reality is a lot of the challenges in palliative care for any serious illness, whether it be cancer or heart disease or dementia, are the items in these squares. The anxiety and worry comes with any serious illness. Depression not only is one of the more common things in every serious illness, but it's an independent predictor of mortality if not addressed. So it's important to recognize it and treat it. Memory problems are pretty specific to dementia, but can, other people with mild cognitive impairment get serious illness as well. So these are kind of ubiquitous as well. Stress, constipation, nutrition and eating, fatigue, nausea, pain, financial implications of the serious illness, dyspnea, all of these things affect people with serious illness. And in dementia, it's even more profound. And I didn't bring up behaviors at first through my first scan through this because I wanted to just spend a minute on behaviors. To me, the special challenge of dementia is that the patient loses the ability to communicate what's bothering them, which makes addressing what's important to them and their goals of care more difficult. And it leaves the patient with the only way to communicate with the outside world is through their behaviors. So we really stress in palliative care that behavior is communication. So if somebody's acting out, it's not behavior just for the sake of it being a behavior that's associated with the disease. Are they in pain? Are they scared? Are they anxious? Are they nauseous? Are they tired? Are they hungry? I mean, they can't tell us. So we need to think about behaviors as communication versus behaviors as something that needs medical attention. Because unless you understand what's causing the underlying behavior, pain, anxiety, depression, whatever it may be, constipation, we can't really truly take care of the patient in a way that is best practice. So additional challenges with dementia, there's an intense emotional component of this. People become, my grandmother became unrecognizable as my sweet grandmother. I learned words from her at the end of her life. I saw her being absolutely awful to people that I know she loved. I was with her, you know, through so many different eras in her life and truly cared about. And she became someone that was almost unrecognizable, which made it incredibly difficult for our family. Making healthcare decisions for themselves or with or for another person is a challenge. Trying to guess what somebody may have wanted or would want in this situation when you maybe haven't had that talk with them. Conflict or different levels of understanding within families. Look, I've been doing this 23 years. Even the best families, the ones that have seemingly everything under wraps and under control, end up with conflict or different levels of understanding at some point, and it creates dynamics. It always bubbles to the surface, no matter how good things look on that surface. Feeling excluded or not part of the healthcare team. Communication's a big deal. When you live long enough that dementia is part of what's happened, it's usually associated with people that are older. Like, there's a lot more going on, and there's a lot of physicians or nurse practitioners or social workers involved, and not really getting the full 360-degree image of what's going on is super frustrating for families and loved ones and caregivers. Affordability of care. It's incredibly expensive to be sick in the United States. It's one of the leading causes of bankruptcy in this country. And it's the same with dementia as any other serious illness. And the other thing that gets super challenging is being able to care for somebody at home, especially as dementia advances. It does get more difficult. And the resources in the home are, I think we've made great strides in the last few years, but they're still somewhat limiting. So palliative care can reduce the suffering. It can prepare families and caregivers for what to expect. It enables care planning and decision making. You can't predict everything that's going to happen in the future, but we kind of know how this is going to play out. And so there are some things we can do so that not everything's a surprise. We address gaps in care that can lead to unnecessary hospitalizations. The phone number that you guys talked about at the beginning of the presentation, number that's available 24/7, incredibly valuable to people so that they don't feel alone. And supporting the caregivers' health and well-being as well. Caregivers are the silent heroes in all of this. The statistics that we went through at the beginning of this they're always mind-blowing to me. And every year it seems like the numbers are getting bigger and bigger as you guys update these stats. And it's just absolutely humbling, the amount of work that people do for the people that they love, at their own sacrifice. So I always joke to my other, like, people I went to med school with or my colleagues, like, I'm the only specialist that everybody ultimately needs. Not everybody needs a cardiologist. Not everybody needs a kidney doctor, but everybody ends up getting a serious illness at some point in their life, and they can benefit from palliative care. Because of that, most large hospitals now have palliative care teams. And it is as simple as asking a doctor that's involved with your loved one's care for a referral. So let's talk a little bit more about caregivers. It's exhausting. I remember at times when I was caregiving, my first wife passed away from cancer, and as she was living through that, this slide just resonates with me, because there was times I remember sitting in the driveway and setting the timer on my phone for 5 minutes, just to gather myself and get up the strength to go in and relieve whoever was covering for me, and knowing what my night had in store for me, caring for my wife. And I do it all again, but it is a fatigue that I have explaining, and I was surprised at how long it lingered, even after my first wife did pass from her malignancy. So it is really takes emotional, physical toll on people. And that needs to be recognized and screened for in caregivers. So no family goes into this thinking this is what they're going to be doing. They're thrust into it. They don't have any training. They have little support. I was lucky. At least I knew some of the medical stuff. I still had people had to come over and help me with some of the flushings of the ports and things like that. And that's me as a physician. So someone who's maybe works outside of healthcare. I mean, imagine having to take care of somebody with complex medical illness with no training and little support. And so that ends up leading to, you know, less than desirable physical, financial, social, and psychological outcomes. And caregiver burden is kind of the term that we use to describe this. And it leads to utilization outcomes for the caregiver and for the patient in the form of increased ED visits and nursing home placement for patients at some point. So what do the caregivers need? Well, we need to include them, make sure they're at appointments, make sure that what they're telling us is documented in the record. We need to screen for their health and well-being and be willing to help them when we identify needs that are being unmet for them. We need care plans for both the patient and the caregiver, and they should be reflective of what the goals are and what's important to the caregiver and to the patient. And caregivers should be referred to the appropriate services that they might need. You know, if they're ignoring their own medical problems, pick up the phone and call their primary doc or one of their specialists and get them in. You know, provide them disease education resources, support groups, and community resources. These are things we do in palliative care all the time. I mean, I pick up the phone all the time on behalf of caregivers and call docs I don't even know and ask, like, I'm with so-and-so. You know, they've really neglected themselves in the care for their loved one. Like, can you get them in? And I'd say I can't remember a time where anybody was ever anything but thankful that that call was made and the patient was referred. And our system doesn't do well with these challenges. Like everything about a chronic debilitating disease does not meet what our health system does well. If you break your leg or you have some sort of orthopedic emergency, there's no place better to be than this country. You can get world-class care for acute, you know, episodic healthcare challenges. For chronic healthcare challenges, we don't do that well. And it's because there's just a mismatch between, you know, what our system is built to do well and what the needs of patients and families are. You know, we are a sick care, technology-driven, disease-driven system that shortchanges quality of life. I learned nothing about quality of life and what's important to patients in medical school. I learned everything about disease and disease treatment. Not everything, a lot though. And outside of palliative care, where I got my training to start thinking about quality of life and to addressing patients' needs beyond their illness, other specialties are not really getting that training. So how do you adequately treat symptoms of somebody who's in distress when you weren't given pain management training, which I was not in medical school? How do you learn that behavior in a dementia patient is a form of communication? That stuff's just not taught. I think that's changing, but it was not taught to my generation of docs. And we need to do better about these issues because this is what's important to our patients and families. They don't want us to be technicians that are focusing only on their illness. So it's not that complicated. People want to live. We need to treat the disease. We need to do the best of what we have to offer in disease-targeted treatment. But we also need to maintain good functioning and high quality of life. This third one, I think, may be the key to it all. People want to know that their care is coordinated and that they're connected to their care team. When my father was sick, he used to tell me, Andy, I don't need any more doctors. I have 8 doctors. I just need 2 that'll talk to each other. And that's so true in our system. We're so siloed that we often don't break down those barriers that are just really artificial and talk to each other. Palliative care does a good job with that. And that's one of the things that patients and families want. And we need support for families to make when they ask questions, but I would prefer to pause here and see what comments or questions the group may have.
So, Andy, this is Michelle Greco. Hi, all from the Alzheimer's Association. I'm monitoring our chat here today. There are not any questions that have come up in the chat yet, but if someone on the call, I do see someone that raised your hand. Neil, if you want to unmute yourself, you can ask your question directly to Dr. Esch.
Hi, yes. Can you hear me okay?
Loud and clear, yep.
Great. Hi, my name is Neil Nagraj. Thank you so much, Doctor, for being here. It's partially a question and also an observation derived from my experience with this. It seemed I've had an experience in a hospital context when my father was hospitalized where I was actually yelled at by a resident or scolded when I asked for palliative care because my mother-in-law was with me and he said, well, we don't need that yet. We're going to fix him. And I think he thought I was like trying to consign him to death or something. But he was very defensive when I said, is there a palliative care team here that could help us and talk to us? Because my father-in-law's condition was fairly advanced and we really wanted him to have a better quality of life. Are you finding, you touched on this about generationally, are you finding that that could be an issue? Are there active efforts in a B2B context to have the conversation you had with us today for other physicians so they learn more about this?
Yeah, this is a great question. And I'm really glad you brought it up because this is part of what we do at the Center to Advance Palliative Care. We have different forms of outreach. Most of my job is education to my fellow colleagues for exactly the reason that speaks to your experience. We also do these sort of patient and consumer facing initiatives. And we also, we do a lot of policy work. So, we do a lot of clinical support and education. And then I think in our policy area, we do a little rabble rousing to try to transform care to be better for people with serious illness. But in my work with training other clinicians, the bottom line is it's not unlike the general public. A lot of clinicians, definitely in my generation, did not know what palliative care was, maybe confuse it with hospice, or just have never heard of it at all. So when it's brought up and somebody like a hospitalist or a resident or somebody like that hears like, well, what about palliative care? It's often the case that they say it's too early for that because they think it's only tied to prognosis. And so one of the things I really try to teach other clinicians is that palliative care is based on need, not on prognosis. So if you see somebody who's struggling, they would be a great candidate for that. I do think it's better with the physicians that are coming out now. Palliative care is in so many hospitals and nurses too. Palliative care is in, I think, almost 80% of the hospitals in the country right now. And so most physicians in training, medical students, nursing students, healthcare students in general are exposed to palliative care. So I'm hoping that's happening less. But a big part of my educational initiative is talking to my colleagues, doing presentations, creating online modules that highlight the benefits of palliative care and try to debunk some of the myths that go along with it, which are you have to be very advanced in your illness to get palliative care, because we actually know that a lot of the benefit of palliative care comes from earlier involvement. There was a great article. We don't put it in these slides anymore because it was put out in 2010, but in the New England Journal of Medicine, they looked at a cohort of patients that got standard care and a cohort that got standard care plus palliative care, and that arm actually lived longer. So once we get more information like that out, once we build up our research base and start distributing it to the other clinicians, I think it will continue to improve. But it is part of the reason my job exists is to address that very thing. The other thing I would just say is, if you're getting pushback from talking to a clinician about palliative care, the getpalliativecare.org website has really great resources for patients, caregivers, families, including, how to talk to your doctor about palliative care, how to ask about it. There's all these great resources on that website that is written in really easy to understand language, not intimidating, and I think very effective. We really have worked on the tools on that website for years. I mean, the 10 years I've been with this Center to Advance Palliative Care, it's all the time we're updating those and really making them as high quality as they can be. So that's a great resource for patients and families.
But Andy, there is one question in the chat that I did want to share, and my sense is it's probably something you'd be getting to at some point. So I'll share it now, and then we defer to you if you want to answer it now or later on. But one of our attendees said, "Thank you so much for the great information. When do you recommend that it be appropriate for someone with advanced Alzheimer's to receive hospice services?"
So hospice is tied to prognosis, where palliative care should be thought of whenever anybody's in distress, suffering, has an unmet need. Palliative care is just really based on need. Hospice is tied to prognosis, and prognostication for Alzheimer's type dementia for hospice care has historically been a challenge, because a lot of the markers are variable between patients. Like, the amount they eat, there's some lab tests that we can order that sort of give an approximation of what the nutritional level of patients are, being bed bound, reduction of fluid, hip fractures. There's certain things that are sort of indicators for eligibility for hospice. My feeling would, my advice for this is, if there's been a significant change, and maybe the patient's not eating or drinking, there's been a fracture and they can't rehabilitate because they just can't comply with the recovery. Those are times where I think asking for a hospice evaluation from one of the clinicians you trust, to make that referral and have hospice come in and see if it is appropriate, is warranted. My experience with most Alzheimer's patients is that hospice visits them more than one time to evaluate them for admission, because the admission criteria are, I don't want to, problematic's not the word. It's just, patients live so long with dementia. It makes identifying the last 6 months more challenging than I think with some other diseases. Do we have any hospice folks on the call? I thought I saw when people were joining, there was some that work with hospices. Maybe somebody could just jump in and comment on what their experience has been. But I think, to meet the requirements for an Alzheimer's diagnosis to hospice care is a challenge, because there's not like a lab test we can do that says, okay, now you're eligible. Whereas in other illnesses, we have other sort of objective markers that make it easier. So I'll pause for a second and see if anybody from a hospice agency wants to chime in. I would also say, as a general feeling, like if something feels like it's not going right, if you're sensing distress, if you're sensing suffering, getting palliative care involved is a great first step, because, if hospice is appropriate, palliative care teams will and should make that transition, just because of the resources that, people get when they do join their hospice benefit as part of their insurance. So, palliative care is always a good first step. Just if they're not involved already, get them involved. And if they are involved, that's a question I would just ask your palliative care providers.
And Andy, on that note, hi all, this is Michelle again. One of our, we have a social worker on who's affiliated with a program, and this is what she shared. I work in a palliative care program that's affiliated with a hospice program. And one of our aims is to capture folks earlier that may be eligible for hospice, so that their suffering can be reduced earlier. And like you were noting, she said, we keep a keen eye in changes in condition that would qualify them for hospice. Yeah,
I agree. Thank you for typing that in the chat. That's reaffirming for sure. Yeah, it's a challenge, but yeah, getting palliative care involved is always a great first step. How about other questions or comments?
There's one other question we have. I'm happy to ask on their behalf. And again, want to encourage folks, if you want to ask yourself, you can raise your hand, but I'm also happy to pose them. Someone asked, is palliative care covered by insurance?
Yeah, I'm paid like any other physician. So yeah, it's billed to insurance. Um, that it's just like any other referral to any other medical subspecialty. So you might be asking yourself, well, how in the world does that work if you're doing social work and nursing care and chaplaincy and maybe other subspecialties? Usually for the patient, palliative care is just seen as another consult to a specialist. On the back end of that, a lot goes into it. Usually hospice organizations, hospitals, community-based clinics subsidize the hospice team so that they do have the full team of people that can address the patient's needs. So, without getting too into the weeds, it is covered by insurance. It is also subsidized usually by an entity behind the scenes, whether that's a hospital or health system, to try to offset some of the costs of being able to provide that interprofessional model of care. Because when my team sees a patient, I'm the only one that can submit a bill to the insurance, and it will only cover what I did for the patient. The social work component, nursing component, that all needs to be bundled up under what I can bill the insurance company. So that's not something I think patients or caregivers need to worry about. I think the most direct answer to the question is yes, it's covered by insurance. Any other questions or thoughts in the chat or from anybody on the call?
See, that's nice. There is some conversation among some of our attendees because we have a blend of, I think, family members, caregivers, and professionals that are here today. So definitely some sharing. There is one person that asked, I know you spoke earlier about behavior as communication, but in terms of palliative care, they said, would love to know what you do for behavior challenges.
Yeah. So to me, behavior is communication. We really drill that into everybody's mind. So then when we approach a patient who is having adverse behaviors, I think about what could possibly be going on. So for instance, my Aunt Dawn had arthritis before she was diagnosed with dementia. Now she's very advanced. This is her 7th year living with dementia. Her arthritis didn't go away. So I had not seen her in a while. And when I visited her in the nursing home she was in, she really had nothing for pain, like no around the clock, no PRN, no as needed. So, trying not to be the nosy outsider coming in, I just, I sort of nudged my cousins to say, like, maybe you could ask if they could start Tylenol around the clock and see if that addressed her behaviors. And it did. And so, I think about the patient as it's just too easy, I think, to see the patient as what they become with dementia and say that, there's the dementia patient. I really try to think about who that patient is as a person. Were they a runner? Were they kind of an anxious person? Did crowds bother them? Did they have arthritis? You really try to think about who that person was and what it was like being them when they could communicate better. And I use that as my checklist to try to find out like what might be causing their behaviors. The other thing I'll say, and this may just be obvious to this group, but is not obvious to some of the clinicians that I teach, is that you have somebody who really has no ability in recency to understand what's going on in their surroundings. Everything is new and scary to them. So now you have strangers coming in the room to undress you, to bathe you. I mean, think about how absolutely terrifying that must be for a dementia patient. Or they're shoving pills down your throat or trying to force you to do something you won't want to do. I mean, fight or flight is a real thing. And so a lot of those behaviors are fight or flight responses to absolutely terrifying situations that we put patients in every day in the name of providing good care. And so I think we need to just rethink how we approach behaviors by looking at them as this is the person trying to tell me something's wrong and start checking off the list. Pain, nausea, constipation, anxiety, depression. I mean, it's amazing what low dose antidepressant can do for somebody who lived their whole life kind of as an anxious person. if they were on an SSRI for 15 years and it somehow got stopped, that didn't go away. And so I don't know, Arlene, I'm giving you a really long answer to say, I think you have to think like a clinician. I think you have to not see the behavior as a behavior and try to solve it like it's a puzzle. And, are there sometimes you still have to give somebody a medication that you're not super comfortable giving just to buy yourself some time until you can figure it out? Yes. But I mean, to me, it feels really cruel. If somebody's in pain and that's why they're acting out, and all I do is, knock them out with an antipsychotic, that just seems not right to me. And so I think approaching it on a what is the cause of the behavior is really the way to go.
Thanks so much. Again, such thoughtful questions and discussion. We do have one more that I'll share now before we move on. And it is, what if palliative care and primary care do not agree on next steps, or if their recommendations differ to a family? How is that handled?
Yeah, Doris, I mean, picking up the phone's always the best way. My kids joke that the phone is an app on their phone that they never use, but like old timers like me, like I still pick up the phone and I'll call and I'll say, what am I missing? Like what am I not seeing? And so I think a lot of times, when you're communicating through a chart or through letters to each other or through office staff, I think things get lost in translation. I don't think there's any substitute for picking up the phone and just coordinating and connecting patients to their care. I hear my dad every day in my career. I just need two doctors that will talk to each other. Your patients, think about how demoralizing that would be if the patient is feeling this tension between a specialist and the primary doc, or two specialists where they're not in agreement or they're hearing different things. I mean, it's unfair to do to patients because I mean, I can't think of a time where I haven't picked up the phone and been able to resolve that quickly. So I think the idea is coordinating that patient's care. And sometimes that may mean that you ask as a caregiver or somebody who's involved with the patient's care at some point, could you call their primary doc because they're saying something different, or saying to the primary doc, you call the palliative care people because they're talking about something that you're not talking about. And so I just think getting people on the phone is key. And really, we don't have to rush through this part of it. When we put these slides together, we purposely kind of make it so that we wrap up in a half hour so that we can have these conversations, because I want to be able to address what's on your mind. I don't want to just talk to you about what I think should be on your mind. So we can go through the frequently asked questions if nobody has more, but my hope is that people have more comments and questions that are directed towards their experience and what may help them. I'm just scrolling through the chat while trying to embrace the silence. Anybody have any hands up? I can only see a few people on the screen here. Okay. Let's see what we got for the frequently asked questions, and this may jar some people's chat box. So what is the goal of palliative care? So to me, it's always about, I want, without life, there's no quality of life. I want people to live as long as they can. I want the best in terms of what we can provide somebody in disease-directed treatment. That's why I went into medicine. I want people to live, but I don't want them to live a horrible quality of life, because I know it doesn't have to be that way. So I also think the second part of this, and just as important, is we have to provide the best of what palliative care has to offer in terms of symptom management, care coordination, addressing spiritual needs, and quality of life. And so, I mean, that's ultimately the goal. Extra layer of support. You can't do one without the other, in my opinion. And that's the way I think people get the best care and the correct care that they deserve. And when do people need palliative care? So again, it's based on need. not prognosis. You don't have to be at a certain stage to get it. I think great triggers for palliative care are anytime you see a change in status, anytime you see somebody who may be suffering. And suffering, there's proxies for measuring people that are in distress or suffering. Missed appointments, emergency room visits, falls. There's just, whenever there's one of those things where you're like, why did that happen? I wonder why that happened. That's a good time to consider palliative care, because the other thing about palliative care that you should know is, like, when we get involved, I would say 9 patients out of 10, we're pretty involved right away. We address what needs to be addressed. We address the symptoms. We kind of coordinate and communicate with the other docs involved to get a big picture of what's going on, get those symptoms under control, get that care coordinated, address any sort of psychological or social things that might be going on, the financial concerns, screening for depression, anxiety, those things that may not have been thought of before. But once we get all that sort of initial lift done up front, if a patient's doing well, we back right off. We'll say, listen, come call us if something changes, or if you have a question. We don't bring somebody into our clinic or go to their home, at some certain interval that works for us. To me, it's like dosing a medication. You give them as much of palliative care or as little of palliative care as they need. And in general, it's a whole bunch up front. And then it gets a little easier as it goes along once you address those things. We had covered this a little bit already. Yes, you can have palliative care along with other treatments. You should. And, we know that there's impact of palliative care that benefits both the health system, but more importantly, the patient and family. It improves their quality of life. It relieves their pain and symptoms, improves family support. And it does reduce hospitalizations and emergency visits. Nobody likes going to the emergency room. And, unnecessary tests and procedures get avoided as well. So again, paying for palliative care, again, it's through billing insurance. So I wouldn't wait. So the question here is, we get this one asked a lot. Should you bring it up to your doctor or wait until the doctor mentions it? You might get reactions like Neil did, where, patient's not ready. But I still think you should bring it up, because most docs were not trained in palliative care programs that are like, middle-aged and older. And so, you want to bring it up, and a lot of times they'll be responsive to it, but it's just not something that was at the tip of their mind or the tip of their tongue to bring up to you. So there's very low risk in bringing it up. Getpalliativecare.org, that website I referenced earlier, does have great resources for how to talk to your doctor. And so, you can bring in a little printout or something like that helps you with some of the language. Because the one thing I know for sure in my days as caregiver for my wife, my father, my grandmother, patients put on the absolute best face when they see their clinicians. I remember my wife being so sick. We would have such a terrible weekend, and I would take her to see her oncologist on a Monday or a Tuesday, and she'd have her hair done, she'd have makeup on, and she would look as good as she had looked in weeks. And it just never really captured what was really going on in the home. So I think you need to bring it up, because your docs may see the face that the patient puts on, but not really see what's going on underneath the surface. And so as a caregiver, I think it's super important to bring those things up. I wish somebody gave me that advice 20 years ago. So when should you ask for palliative care? I mean, if you're thinking about it, you should ask for it. If you're seeing pain, if you're seeing other symptoms, if you're seeing increases in behaviors, it's a low risk ask. You're getting a trained team of specialists coming in that are thinking about nothing other than the quality of life for the person that you care about. I don't see a downside to that. If we can't help, we tell you, or we help to the point we can, and then we back off. Like, this is not, it just seems like a very low risk, high yield proposition. And explaining to your doctor that you want that referral. I think most are receptive to it now. You will get the occasional hospitalist or somebody in training that maybe is not not a proponent of palliative care, doesn't know about it, but I think that's getting fewer and further between. I'm seeing there's some activity in the chat, so I'm just peeking at that. Yeah, so I'm not sure the answer to the question if there was a rerun for this, but I heard that it was being recorded, so that's probably going to be made available to you. But I'll wrap up here because I think we're kind of nearing the end, and I want to give another maybe couple minutes at the end for any questions that might have come up. But the resources for palliative care, I mean, there's the Alzheimer's specific resources are always great. And honestly, whenever I build any training for any clinicians that I teach to, I use the Alzheimer's Association statistics and information as part of my presentation because the resources that you guys have are excellent. For palliative care specific resources for patients and families, there's nothing like getpalliativecare.org. Sure, I'm biased. Sure, it's our site. I had nothing to do with putting it together, so I don't get any kudos for it, but it is just written in clear, concise language. It gives you a checklist about answering some questions to find out if palliative care is right for you, some information on how to get it, how to talk to your physicians or other clinicians about it. There's a blog written that is directed towards patients and families. There's disease-specific resources for palliative care by different diagnosis. So, like if you have, heart failure, there's a whole information page on heart failure. Dementia, there's an information page on that. There's provider directories where you can search by where you live to see what palliative care is available near you. And I think, the two things that I found most powerful, I find most powerful every time I go to the site are the patient and family stories that are recorded on there and the what you should know handout. Like it just gives you great information that can empower you to get this extra layer of support for the person that you're caring for. And thank you. It looks like the link got put up in the chat box too, but it really is a beautiful site, really well done. So with the few minutes we have left, I'll pause. Anybody with any questions or comments, please chime in. I'm happy to do the best I can to answer or comment back. Okay. I wasn't expecting this group to be as quiet. I think when I presented in the spring, there was more questions, but if at any point anybody has any questions that popped up or maybe we're too shy to ask in front of the group, let me just put my email in the chat. It's not very complicated. It's pretty easy to remember or take a quick screenshot of. It's just my first and middle initial and last name, all lowercase, and at gmail.com. And I'm happy to respond if someone had something they just didn't want to share with a group and maybe wanted to ask in private. That is a-okay with me. So I just want to thank you for having me. It really is one of my favorite parts of my job is being able to interact with groups that are really close to the work. So thank you for all you do and thank you for having me.
And Andy, on behalf of the Alzheimer's Association New York City chapter, we really want to thank you so much for your time today. I could tell just how valuable this was to all of our attendees, and I have no doubt that some follow-up questions will come. I also want to thank Kevin Bleyer, our volunteer who kicked the session off today. I think, again, I'm here as staff and we are deeply committed to the work that we do, but hearing directly from those of you who are living these things or have lived them in your day-to-day life, I think brings all the connections together. So to wrap this up, I want to again thank getpalliativecare.org, the Center for Advance Palliative Care, Mount Sinai, and Dr. Andy Esch for partnering with us today on this really, really important program. I will be following up with all attendees and send you, I know we put a lot of good information in the chat. I'll pull together a summary of the links and resources that were shared so you can follow up with those resources as well. And for that, thank you all for attending. Thanks for making your time to join us today, and have a great rest of your afternoon. Bye-bye.
Bye, everyone.